Bismillahirrahmanirrahim. Now let's talk about the alkaline secretion is stimulated by. We were talking about the alkaline secretions in the duodenum. Those secretions were coming from number one, the Brunner glands, and number two, the epithelial cells of the pancreatic ductules. These two were the cause, were responsible for secretion of the, what do we call them, the bicarbonate ion in the duodenum, because duodenum is facing the acidic kind coming from the stomach. Now here they are saying that the alkaline secretion is stimulated by the tactile stimulation of the duodenal mucosa, increased parasympathetic activity following the meals, and the presence of acid in the duodenum and jejunum causes the release of secretin from the mucosa, stimulating the secretion of bicarbonate from the submucosal glands and pancreas. So these three are the stimuli which help secrete the bicarbonate from the Brunner gland and the pancreatic ductules. Number one is the tactile stimulation. Whenever the food is entering the duodenum, like suppose this is the duodenum attached to the stomach behind that. So this is something that we can think of to be stomach like this, and maybe something like that. So when the food enters the duodenum, it touches the walls of the duodenum, and when there is a tactile stimulation to the duodenal mucosa, that allows the bicarbonate secretion. The second one is the increased parasympathetic activity following the meals. Whenever you are done eating, there is an increased parasympathetic activity in your body, and that parasympathetic activity stimulates the vagus nerve, and the vagus nerve is going to enhance the peristalsis throughout the GIT. Number three is the presence of acid in the duodenum. Whenever the duodenal and jejunal mucosa encounters the acidic content coming from the GIT, coming from the stomach, so the secretin is produced from the mucosa, stimulating the excess secretion of the bicarbonate from the submucosal glands and pancreas. Excess gastric acid secretion, such as seen in the Helicobacter pylori infection, can cause increased production of secretin that over time can lead to the hyperplasia of the submucosal glands. So, in the case of H. pylori infection, when we are talking about the chronic gastritis and stuff like that, we have to keep in mind that during that particular scenario of H. pylori infection, because excessive acid is being produced, so that excess acid production can lead to the Brunner gland hyperplasia or submucosal gland hyperplasia. But later on, we will see that with H. pylori infection, not with H. pylori infection per se, but we'll see that in the chronic gastritis that ultimately, initially, there is increased acid production, but in the long run, the acid production is diminished in the chronic gastritis. Then the Uworld point is that features of the large intestine. The large intestine contain appendices, epiploic appendices. I guess these are the omental appendices. These appendages are called omental appendices, or maybe appendices epiploic. Then seculations or house stations, as you can see, there are indentation like this and this and this and this. So sorry. So these are seculations, and then we have the tinea coli. Tinea coli are three bands of muscles, like the one you can see over here. This is the tinea coli. The tinea coli meet together at the base of appendix, where they form a complete longitudinal muscle coat of the appendix. So the very first thing that you must remember is that they are longitudinal muscle. Like if I could zoom it in, so you can see that these are longitudinal muscles. They are directed in this direction, in the linear fashion in the longitudinal axis. So these are longitudinal muscles. Secondly, there are three bands of that, one on the anterior side and two lateral bands. They fuse together at the appendix, where they form a single longitudinal coat. So complete longitudinal muscle coat for the appendix. Then there is the Uworld point about the tinea coli. They are used as a surgical landmark for appendectomy. Begin as a continuous layer of the longitudinal muscle that surrounds the rectum just below the serosa. At the rectosigmoid junction, this layer condenses to form three distinct longitudinal bands that travel on the outside of the entire colon before converging at the root of vermiform appendix. Okay, at the rectosigmoid junction, this layer condenses to form three longitudinal bands. Okay, so basically they are continuous in the rectum. They have started, like if you could see this picture, so you can see that there is a continuous longitudinal coat of the rectum as well. Like they are continuous, and then they condense to form three bands. Like one band is going like this, and there are two other bands. So these bands move all the way down here, and then again they converge at this point to over the vermiform appendix. At the rectosigmoid junction, this layer condenses to form three distinct long bands that travel on the outside of the entire colon before converging on the root of vermiform appendix. The tinea coli have a similar function as the outer layer of the muscularis externa in other portion of the digestive tract. That when we talk about the muscularis propria, so or the muscularis externa, we say that there is an inner circular muscle layer and there is an outer longitudinal muscle layer. There is a continuous coat. I'm just drawing straight lines. just to depict that the outer layer of the muscle is longitudinal muscle and the inner layer is the circular muscles. So it is the main function of these longitudinal and circular muscle is to exist in the peristalsis. If the appendix cannot be identified by palpation during an appendectomy, it can be located by following the tinea coli to its region at the cecal base. The Peyer's patches in the ileum contain the specialized cell called as the M cells. So Shigella, so basically the Peyer's patches are the aggregates of the lymphocytes which are present in the submucosa of the ileum, and just above that we have some cells which are called as the M cells, which bring the antigens and present them to the lymphocytes. So Shigella exhibit the specificity for the M or the microfold cells. M cells are specifically designed to sample the contents of the gut lumen and transfer the antigen to their basal lamina within the endosomes. At the base of the cell, within a special pocket, microfold await the macrophages and lymphocytes ready to mount an immune response. At the base of the cell, at the base of M cell, within a special pocket which is called as a microfold, awaits the macrophage and lymphocytes which are ready to mount an immune response. Shigella first penetrates the mucous membrane by the gut by passing through the M cells. Following the host epithelial cell invasion and penetration of the mucosa, Shigella infection is characterized by the degeneration of epithelium due to inflammation of the lamina propria and bacterial spread laterally from M cells to other mucosal cells. So basically, the Shigella has the capability to evade the immune response, so it spreads laterally from one M cell to the next M cell. The result is denuding and ulceration of the mucosa and subsequent leakage of the fluid, inflammatory elements and the mucus into the intestinal lumen. Patients pass frequent stool mixed with blood and mucus, so there is dysentery or bloody diarrhea. As in most forms of diarrhea, stools are frequent and loose because the absorption of water by the colon is inhibited. When the colon is, when the intestinal lumen and the when the intestinal mucosa and the colonic mucosa that becomes inflamed, so the water reabsorption is decreased and resultantly there are frequent loose stools characteristic of the diarrhea, and that is also tinged or maybe containing frank amount of blood because this is a kind of dysentery. Then you will point about the Penneth cells, small group of cells at the base of intestinal crypts. These have both phagocytic and secretory properties and thus provide the first line of immune defense against the intestinal microorganism. The Penneth cells are present at the base of intestinal crypts. So when we look at the microscopic picture of the intestine, there are villi, and then between the villi we have downward indentation which are called as the crypts. So there are villi and then we have crypts. So these are crypts moving downwards, and these are the villi, and above them we'll have microvilli as well, which will be seen with the electron microscopy. So the Penneth cells, they have both phagocytic and secretory properties and thus provide the first line of immune defense against the intestinal microorganisms, and they are small group of cells at the base of intestinal crypts. They secrete the lysozyme, an enzyme capable of dissolving the cell wall of many bacteria and defensins polypeptides that have the antimicrobial and antiparasitic activity. So the Penneth cells are responsible for the production of lysozyme, which dissolve the cell wall, and the defensins, which are polypeptides that have antimicrobial and antiparasitic properties. Now let's talk about the histology of stomach. On the surface we have the histology of the stomach. The surface of stomach contains the mucous glands. There are two types of glandular layers, upper glandular layer and the lower glandular layer. There was a picture of that, I guess over here. Yes, here you can see that there is an upper glandular layer, and then we have a deeper aspect of the gastric glands that is present over here. Let's see them. So they are saying that the upper glandular layer contains the parietal cells which produce HCl plus intrinsic factor. The deep glandular layer have the chief cells and that produces pepsinogen secretion. Okay, so I'm sorry. So the upper glandular layer, that is containing the parietal cell. Parietal cell produces HCl. Now most of the people remember HCl, but intrinsic factor is also produced by the parietal cell. You must remember that as well, because there are conditions like pernicious anemia in which we have antibodies which are targeting the parietal cells, and when the parietal cells are being targeted, the intrinsic factor is not produced, and that is that the pernicious anemia. We'll study that in detail when we do the autoimmune version of the chronic gastritis, but for right now just remember that the upper glandular layer contains the parietal cells, then the deep glandular layer contains the chief cells. Yes, and that is responsible for the pepsinogen secretion. This pepsinogen is a proenzyme. It will be converted into the active form, that is pepsin, after the exposure to the HCl. So here you can see the mucosa. This is the mucosa, but this is the mucosa of small intestine, I guess. Yes, So this is not stomach, this is the small intestine histology. So above that you can see this is mucosa. These finger-like projections that are moving into the lumen or moving outwards, these are villi. These indentations are called as crypts of Leverkuchen. Then we have lamina propria just below the epithelium. Then the stem cells are present in the crypts of Leverkuchen. That is very important. Whenever there is damage to the intestinal lumen, and that is very frequent, like whenever you are ingesting something, whenever there is acid exposure or stuff like that, there is rapid turnover of the cells of the GIT lumen. These are the most, the cells with the most amount of mitosis in our body is going on in the GIT cells. So you must remember it like that. That the crypts of Leverkuchen contain the stem cells for the regeneration of the intestines. There is another point that just came to my mind. You know, there is a drug that is called methotrexate. Methotrexate is an anti-neoplastic drug. We give that for the cancer treatment because the methotrexate stops the rapid proliferation of the cells wherever it is going on in the body. You know, the tumor cells are rapidly proliferating, so it stops the tumor cell proliferation. On the same lines, there is a side effect of methotrexate that is called as stomatitis, and that stomatitis is happening because that happen mostly in the mouth. But you must remember that the GIT cells, starting from the oral cavity all the way down to the inner canal, there is rapid proliferation of the cell and rapid turnover of the cells, and due to that rapid turnover, any neoplastic drug can cause the damage to the GIT cells. Then we have the stem cell in that muscularis mucosa is a part of the mucus. So these three layers constitute the mucus. Number one is epithelium, then we have the lamina propria, and after that we have the muscularis mucus. So these three layers collectively they constitute the mucosa. Below the mucosa we have submucosa, this one. Then below the submucosa contain the blood vessels, and between the mucosa and submucosa we have the Meissner's nerve plexus, that is also called as the submucosal nerve plexus. Submucosal because it is below the mucosa. So between the mucosa and submucosa we have submucosal nerve plexus, and that is responsible or resisting in the secretions of the glands. Then we have the muscularis propria. So the muscularis propria is present over here. Then below the muscularis propria we have the serosa, and these are the blood vessels. And then we have the myenteric nerve plexus. The myenteric nerve plexus, you must remember that it is present between the muscularis propria and the serosa. I don't think so. It's not present between the muscularis propria and serosa. It is present between the inner circular layer and the outer longitudinal muscular layer of the muscularis propria, between the two muscle layers, and that is going to resist in the motility. Moving forward to this point, that is abdominal aorta. So the abdominal aorta, the arteries supplying the GIT structures are single and branch anteriorly. The arteries supplying the non-GIT structures are paired and they branch laterally. So there is a basic concept about the abdominal aorta, that suppose this is the abdominal aorta. So there are some arteries which are branching anteriorly and or maybe posteriorly. So the arteries which are branching anteriorly or posteriorly, they are singular arteries, they are not paired. But the arteries which are supplying, and these are the arteries which supply the GI structures. All the arteries which are originating from the abdominal aorta and supplying the GI structures are unpaired arteries. The arteries that are supplying non-GI structure like kidneys or maybe other stuff like that is present in the abdomen, they are originating laterally and they are also paired. We'll see that later on, but this is basic scheme that you must remember. So here you can see that they have written that the arteries supplying the GI structures are single and branch anteriorly. The arteries supplying the non-GI structures are paired and they branch laterally and even posteriorly. I'm sorry, the posterior arteries are also branched. Only anterior arteries are unpaired, while the posterior arteries and the lateral arteries are paired. Superior mesenteric artery syndrome. Superior mesenteric artery syndrome is characterized by the intermittent intestinal obstruction symptoms, primarily the postprandial pain. When the superior mesenteric artery and the aorta compress the transverse or third portion of the duodenum, typically occurs in the condition associated with the diminished mesenteric fat, for example, the low body weight or maybe malnutrition. Two areas of colon have dual blood supply from the distal arterial branches, the watershed regions. Okay, let's talk about this first. We have talked about this before when we were talking about the duodenum. So in the duodenum, you can see, like there was a picture over here. This one. So here you can see that the superior mesenteric artery moves above the duodenum, above the third or the horizontal part of the duodenum. This is the horizontal part of duodenum, and the superior mesenteric artery is traversing over that. Now this is the cross section of that. You can see that between the superior mesenteric artery, this over here, and the abdominal aorta over here, we have three structures. The first one is the left renal vein. Second thing is the third part of the duodenum, and the third thing is this yellowish thing, that is the fat pad which is cushioning the duodenum and the left renal vein. Whenever the person is malnourished and there is decreased amount of fat in the body overall, maybe in anorexic patient, maybe in a malnourished patient, or maybe in a chronically sick patient, the fat pad is dissolved, and when the fat pad is gone, the superior mesenteric artery is coming closer to the aorta, and that compresses the duodenum and the left renal vein, and that have its own share of consequences. Now let's see over here. So you can see that it may result in the obstruction symptoms. For example, primarily the postprandial pain when superior mesenteric artery and aorta compresses the transverse portion of the duodenum, typically occurs in the condition associated with the diminished mesenteric fat, for example, the low body weight or maybe malnutrition. Two areas of colon have dual blood supply. So whenever we talk about dual blood supply, it is a good and a bad thing simultaneously, because if we say that the segment of colon has dual blood supply, so it looks something like this. Like one artery is giving its branches, terminal branches, and the other artery is also giving its terminal branches to supply a particular area. So this kind of area is called as watershed area because it is not supplied completely by any of the arteries. It is partially supplied by this artery and partially by this artery. So it is a vulnerable area in the cases of hypovolemia, or whenever there is a condition of shock and the blood supply is decreased. So two areas of colon have dual blood supply from the distal arterial branches, watershed regions. It's a bad thing in this sense, but when is it a good thing? When we talk about liver, so liver has a dual blood supply. It has a portal circulation as well as the hepatic circulation. So it is kind of immune to the ischemia. So that depends on the anatomy of the dual circulation. The 2 points which we are going to talk about are the splenic flexure and the rectosigmoid junction. They are also called as watershed areas, and they are susceptible in the colonic ischemia. The splenic flexure is supplied by superior mesenteric artery and inferior mesenteric artery. Splenic flexure is like this. Is suppose this is ascending colon, then we have transverse colon, and then descending colon. Above here we have spleen. So the flexure of the colon that is present just below the spleen is called a splenic flexure, and that is supplied by the branches of superior mesenteric artery and inferior mesenteric artery. The rectosigmoid junction, which is present like over here, this is a sigmoid colon, and then we have the rectum. This is sigmoid colon, and then the rectum is present over here. So this rectosigmoid junction, that is the last sigmoid arterial branch of the inferior mesenteric artery and the superior rectal artery. So these are the branches which are supplying the rectosigmoid junction. This splenic flexure is also called as the Griffith point, and this rectosigmoid junction is also called as the Sudeck point. So remember that. And now let's see the different branches of the aorta. Here you can see that the aorta is present posterior to the inferior vena cava, or you may say that the inferior vena cava is present anterolateral to the aorta. Aorta is the most posterior most structure in the abdomen because it is located just over the vertebral column. Now at the level of T12, it is giving rise to the inferior phrenic artery, the superior suprarenal arteries, and the middle suprarenal arteries bilaterally. So the inferior phrenic artery is going to the diaphragm. The superior and middle suprarenal arteries are going to the adrenal gland. Like suppose this is the kidney, and then we have the adrenal gland. So adrenal gland is getting its supply from the superior, middle, and inferior suprarenal arteries. Superior and middle suprarenal arteries are originating at the level of T12, that is just below the diaphragm. And at the level of L1, we have okay. Let's talk about the paired arteries, and then we'll come to the GIT arteries. At the level of L1, we have inferior suprarenal arteries. This constitute a set of the arteries which are going to the adrenal glands or suprarenal glands. Then we have a pair of renal arteries that is also originating at the level of L1. Then at the level of L2, we have the gonadal arteries. They are also paired. And then there are other arteries like ureteric artery or stuff like that, which are not very important to be mentioned here. At the level of L4, there is the bifurcation. The bifurcation at the level of L4, and the bifurcations are basically happening at some 4 level. Like for the aorta, it is L4. For the the other thing, the trachea, it is T4 and stuff like that. So bifurcation is having at the level of L4 into the right common iliac artery and the left common iliac artery, and then the common iliac artery then get itself divided into external and internal iliac arteries, and then we have the median sacral artery and stuff like that. Now let's come to the GI arteries. At the level of T12, we have celiac artery. Celiac artery is the blood supply for the foregut, and when I say the foregut, I am specifically referring to the part of the gut that is below the diaphragm. Although it has been started from the oral cavity and all that, but in very strict terms, the foregut is the area of the gut that is being supplied by the celiac artery, and that starts from abdominal esophagus, the stomach, and the 1.5 part of the duodenum, like the second part of the duodenum up till the opening of the major duodenal papilla, where the pancreatico-duodenal duct is, and the pancreatico-biliary duct is opening into the duodenum. at that point, that is the foregut. Then at the level of L1, we have superior mesenteric artery. Superior mesenteric artery is going to supply the duodenum, from the second part of the duodenum all the way to the ileum, then the ascending colon, and then proximal 2/3 of the transverse colon as well. Then we have inferior mesenteric artery that is originating at the level of L3. The inferior mesenteric artery is going to supply the distal transverse colon, the descending colon, the sigmoid colon, and sigmoid colon and some part of the rectum as well. So these are the blood supplies. So this is the hind gut. So celiac artery is supplying the foregut, superior mesenteric artery the midgut, and the inferior mesenteric artery is going to supply the hind gut. Then there is a Uworld point about the inferior vena cava. It formed by the union of the left and right common iliac arteries at the level of L4 and L5. So the inferior vena cava is forming at the level of L4, the same point where the aorta is bifurcating. So at the level of L4 and L5, by the union of common iliac arteries, like the common iliac veins, the right and left common iliac veins, they fuse together at the level of L4 or maybe L5 to give rise to the inferior vena cava. It lies just anterior to the right renal artery. The right renal artery, where is it? It is renal artery, like this one is the right renal artery behind the inferior vena cava. So inferior vena cava is situated anterior to the right renal artery at the right of aorta, enters into the right atrium just above the diaphragm, above T8 level. So it is entering the diaphragm at the level of T8. Okay. Then we have next point, that is about the foregut, midgut, and hindgut, and there are stuff like that. I guess this table is also taken from the 100 anatomy points. Those videos will be uploaded soon, inshallah. So the foregut contains esophagus, stomach, duodenum first and second parts, liver, pancreas, biliary apparatus, and the gallbladder, and also the spleen. It is highlighted because spleen is a midgut, not a midgut. Spleen is not a foregut derivative. Spleen is coming from the mesoderm. All the foregut derivatives are endodermal in origin, while the spleen itself is a mesodermal organ. It is mesodermal in origin. It is developing from the mesenchyme, but it is supplied by the celiac artery. That is why we classify it as a foregut organ. Then we have the artery, that is celiac artery. The parasympathetic innervation is coming from the vagus nerve, that is cranial nerve 10, and the sympathetic innervation is coming from the preganglionic, like the greater splanchnic nerves. Remember, the greater splanchnic nerves are going to supply the foregut, the T5 to T9, and the postganglionic are the celiac ganglion. The basic, the celiac ganglion. So for the sympathetic innervation, the basic framework is that a neuron, the preganglionic neuron, comes from the spinal cord all the way to a neuron, to a ganglia that is situated somewhere. For example, in this case, we have celiac ganglion, and then this celiac ganglion will give rise to the post-sympathetic neurons and stuff like that. So this is the basic framework in the case of sympathetic innervation. Then we have, the sensory innervation is coming from the dorsal root ganglion at the level of T5 to T9, and the referred pain is to the epigastrium. It is very important to remember that whenever there is some kind of pathology going on in the GIT, that will refer the pain to the epigastric region. If I draw the abdomen like this, suppose this is the abdomen, like this, and over here, yep. So this is the abdomen of a person. So this region is the epigastric. Like we divide the abdomen into 9 quadrants, right? Something like this, 1, 2, and then we have this. These are the 3 quadrants. So this particular quadrant is called the epigastrium, right? So in the referred pain to the referred pain from the foregut is going to the epigastrium. The referred pain from the midgut is going to the umbilical region. The umbilicus is present over here, so it is going to the umbilical region, and the referred pain from the hindgut is going to the hypogastrium, right? So other quadrants are epigastrium. These are the hypochondriums. These are the flank regions or the lumbar regions. None of these are flank regions basically. And then we have, okay, these are the lumbar regions, but we have to, let me check the names of that. So here you have the names: the epigastric region, the left and right hypochondriac regions, umbilical region, the left and right lumbar regions, and then we have the hypogastric region, the left and right inguinal regions. So these are the lumbar regions, these are the inguinal regions. Remember that. Now let's come back to our discussion. So the second thing is the midgut. Midgut is starting from the duodenum, the second, third, and fourth parts, the jejunum, the ileum. Then we have the cecum with appendix. Appendix is also a part of the midgut. Then we have the ascending colon, the transverse colon, proximal 2/3 of the transverse colon is also included in the midgut. The artery that is supplying the whole of the midgut is the superior mesenteric artery through its different branches. The innervation is from the parasympathetic innervation, the vagus nerve, The sympathetic innervation, so the parasympathetic innervation, basically for the parasympathetic innervation there is a very long preganglionic neuron that is ending at the organ. For example, we are talking about the stomach over here. So that presynaptic neuron will go all the way to the organ, and then the postsynaptic ganglion that is present on the surface of the organ, and that gives rise to innervation of the organ and stuff like that. The parasympathetic innervation of the foregut and the midgut is coming from the vagus nerve. The sympathetic innervation is from the preganglionic, from the lesser splanchnic nerves. For the foregut, it was the greater splanchnic nerves at the level of T5 to T9. The sympathetic innervation is from the midgut is coming from the preganglionics, from the lesser splanchnic nerve at the level of T10 to T11. The postganglionics and the superior mesenteric ganglion. The sensory innervation is at the dorsal root ganglion at the level of T10 to T11, and the referred pain is going to the umbilicus. There is a straight line. The epigastrium is containing the pain or the referred pain from the foregut. The umbilicus is containing the referred pain from the midgut, and then in the this region is called the hypogastric region. Yep. So in the hypogastric region, we are going to get the pain from the hindgut. So here you can see that in the hindgut, it involves the transverse colon distal 1/3, the descending colon, sigmoid colon, rectum, anal canal above the pectinate line. The artery is inferior mesenteric artery. The parasympathetic innervation into the pelvic. The parasympathetic innervation for the hindgut is coming from the pelvic splanchnic nerves. Okay, so the vagus nerve is supplying the midgut and the foregut, while the hindgut is being supplied by the pelvic splanchnic nerves originating at the level of S2 to S4. Sympathetic innervation is coming from the lumbar splanchnic nerves L1 and L2, and the postganglionics are the inferior mesenteric ganglion. So the ganglion, the sympathetic ganglion for the foregut was celiac ganglion, for the midgut it is superior mesenteric ganglion, and for the hindgut it is inferior mesenteric ganglion. That is, the name of the ganglion is similar to that of the artery. It is the midgut is supplied by the superior mesenteric artery, and the sympathetic ganglion is superior mesenteric ganglion. The hindgut is supplied by the inferior mesenteric artery, and the ganglion that is supplying innervation, giving innervation to the hindgut, that is the inferior mesenteric ganglion. Then the sensory innervation is by the dorsal root ganglion from L1 to L2 level. The referred pain is going to the hypogastrium. This is the azygous venous system. So here you can see about the azygous vein that it is a parallel system to the inferior vena cava. The ascending lumbar veins, the right subcostal vein, then the hemiazygous vein. All of these things fuse together to form the azygous vein. The posterior intercostal vein, the accessory hemiazygous vein, like the azygous vein is present over here. This thing is called the azygous vein that is draining the lumbar area as well as the thoracic area. So it is it is a collateral circulation for the inferior vena cava as per my concept, and then superior vena cava is over here. There is subclavian vein and the internal jugular vein and stuff like that. So azygous vein goes all the way and drains into the superior vena cava. So inferior vena cava is running like that, and the azygous system is coming from because the basic concept about, suppose this is the heart, and the superior vena cava drains the upper part of the body, and the inferior vena cava drains the lower part of the body, right? While the azygous venous system, it is draining the lower part of the body like the lumbar region or maybe the subcostal region, and it is draining all the way into the superior vena cava. So you must remember like that. Then moving forward to the next point, that is about the celiac trunk. The celiac trunk is the first branch of the abdominal aorta inside the abdomen that is going to supply the GIT structure, that is the main blood supply for the foregut, and that is originating at the level of T12. So the branches of the celiac trunk are the common hepatic artery, the splenic artery, the left gastric artery. These constitute the main blood supply for the stomach. Strong anastomosis exists between the left and right gastroepiploic arteries and the left-right gastrix. This is a better picture. So here you can see this artery that is depicted over here. This is the celiac artery over here. The celiac artery is giving rise to the splenic artery like this. It is going to give rise to the common hepatic artery. The common hepatic artery will give rise to hepatic artery proper like this, and the gastroduodenal artery which is going to descend downwards. Now let's talk about some main arteries which are coming from the celiac artery. So from the celiac artery, the main branches of the celiac artery are the splenic artery, the left gastric artery, right? There is the left gastric artery which is coming all the way down. Then we have the common hepatic artery. The common hepatic artery, these three are the main branches of celiac artery. Then now let's talk about the subsequent branches of these arteries. So the left gastric artery will give rise to the esophageal branches. The common hepatic artery is going to give rise to the gastroduodenal artery which will descend downwards, and the proper hepatic artery which will descend upwards. The proper hepatic artery will then be divided into left hepatic artery, the right hepatic artery, and the cystic artery. The gastroduodenal artery, this one, it will get itself split into anterior superior pancreaticoduodenal, and then the anterior superior gastro pancreaticoduodenal. While this artery giving is also going to give rise to the right gastroepiploic artery and the posterior superior pancreaticoduodenal artery. Now, the main arteries that you must remember are the arteries which are anastomosing at the curvature of the stomach. Like at the lesser curvature of the stomach, we have the anastomosis between the left gastric artery coming as a direct branch of the celiac trunk, and the right gastric artery which is coming as a branch of the proper hepatic artery, and they anastomose at the lesser curvature of the stomach. For the greater curvature of the stomach, you must remember about the right gastroepiploic artery which is coming like this, and the left gastroepiploic artery which is a branch of the splenic artery like this. Then we have, these are the supplies of the lesser curvature and the greater curvature. So now let's come to this depiction. So let's see this diagram and then we'll go to that. We'll move in a counterclockwise fashion. So firstly, you must remember that this is the abdominal aorta. The abdominal aorta is going to give rise to the celiac trunk like this. Then we have the left hepatic artery, the right hepatic artery, then there is a cystic artery, proper hepatic artery is coming like this. The common hepatic artery is, there is a direct branch of the celiac artery, while the proper hepatic artery is coming from the common hepatic artery. Then the gastroduodenal artery, like this one, the anterior superior pancreaticoduodenal, posterior superior pancreaticoduodenal, we have talked about that. There is the right gastric artery, and the right gastric artery is also coming as a branch of the proper hepatic artery. Then the right gastroepiploic artery. Then here we have the left gastroepiploic artery coming from the splenic artery. The splenic artery like this. The splenic artery also gives rise to short gastric artery, which is going to supply the fundus of the stomach, maybe some part of the body as well. Then there is left gastric artery and the esophageal branches like that. So these are the areas. They have colored the areas for specific blood supplies. The purple areas for the left gastric artery, like this area, that is given by the left gastric artery, even moving upward into the esophagus as well, the abdominal esophagus. So this area is supplied by the left gastric artery. The orange area is supplied by the splenic artery. Splenic artery gives rise to short gastric artery and stuff like that. Then we have this area, the blue area, that is supplied by the common hepatic artery. Why common hepatic artery? Because common hepatic artery is going to give rise to the right gastric artery as well as the right gastroepiploic artery. So this is the area, the blue area is being supplied by the common hepatic artery. Now in this picture you can see the same arteries once again. So there are, we'll move in a counterclockwise direction. This is the celiac artery. Celiac artery is giving rise to the to the common hepatic artery, which get itself split into the proper hepatic artery. The proper hepatic artery gives rise to the right gastric artery. Then we have the gastroduodenal artery as a branch of the maybe you can say that common hepatic artery or maybe the proper hepatic artery, but it is also coming from the celiac artery. It will give rise to the anterior superior pancreaticoduodenal arteries and posterior superior pancreaticoduodenal arteries. The right gastroepiploic arteries will move rightwards on the greater curvature. The left gastroepiploic arteries will move downward on in the same fashion on the greater curvature. There is a splenic artery, then we have the spleen. The short gastric arteries are coming from the spleen. Then there is left gastric artery that is coming from as a direct branch of the celiac trunk. The esophageal branches of the left gastric artery are moving upwards. Then in this picture, moving downwards, you can see the left gastric artery like this thing. So the left gastric artery courses upward to the left to reach the lesser curvature of the stomach and may be subject to erosion by the penetrating ulcer of the lesser curvature of the stomach. Okay, the branches of the left gastric artery are the esophageal branches, like over here, to the abdominal part of the esophagus, and the gastric branches supply the left side of the lesser curvature of the stomach and make anastomosis with the right gastric artery. What is common hepatic artery? The common hepatic artery passes to the right to reach the superior surface of the first part of duodenum. The common hepatic artery passes to the right, like it is passing to the right side, to reach the first part of the duodenum, where it divides into terminal branches, which are the proper hepatic artery, and then there is gastroduodenal artery. So gastroduodenal artery, which moves downward, it is a branch of common hepatic artery. Then we have proper hepatic artery. Proper hepatic artery is moved upwards, like this artery, which is moved upwards. It is a branch of the common hepatic artery, but it moves upwards. The proper hepatic artery gives off the right gastric artery. Okay, so I'm not actually highlighting everything because we have read that before. So it gives rise to the right gastric artery and then ascends within the hepatoduodenal ligament. Do you remember what is hepatoduodenal ligament? The hepatoduodenal ligament is the anterior border of the anterior border of the epiploic foramen. It is an attachment between the liver and the upper part of the duodenum, and it contains a portal trigid. So the hepatoduodenal ligament of the lesser omentum to reach the porta hepatis, where it divides into the right and left hepatic arteries. The right and left arteries enter the two lobes of the liver, with the hepatic artery first giving rise to the cystic artery to the gallbladder. The right gastric artery supplies the right side of the lesser curvature of the stomach, where it anastomoses with the left gastric artery. The right gastric artery supplies the right side of the lesser curvature of the stomach, where it anastomoses with the left gastric artery. The ligature of the hepatic artery. There is a maneuver that we call the Pringle maneuver. We'll talk about that. The hepatic artery may be ligated proximal to the origin. The hepatic artery may be ligated proximal to the origin to its gastroduodenal branch. A collateral circulation of the liver is established through the left and right gastric arteries. So, if we are going to ligate the hepatic artery, suppose we ligated it over here, like they are saying that we have to ligate the hepatic artery all the way at this point. So, if we are ligating the hepatic artery proximal to the origin of the gastroduodenal branch, a collateral circulation of the liver is established through the left and right gastric arteries, because you know the right gastric artery is coming like this and the left gastric artery is coming like this. So, the blood will move from the left gastric artery into the right gastric artery, and then from the right gastric artery into the proper hepatic artery going all the way to the liver. So, we can ligate the common hepatic artery over there without compromising the blood supply for the liver. And the left and right gastroepiploic arteries and the gastroduodenal arteries. And for what? To the left, yes, and left and right gastroepiploic arteries. The gastroepiploic arteries can also give rise to the collateral circulation, like this is the gastroepiploic artery. The left gastroepiploic artery will shunt the blood into the right gastroepiploic artery, that will go into the distal to the obstruction and then to the liver and stuff like that. The right hepatic artery may be mistakenly ligated during the holocystectomy in the Callet triangle. There is a triangle that is called the Callet triangle. When we are removing the gallbladder, like in the holocystectomy, the right hepatic artery may be mistakenly removed. The Callet triangle together with the cystic artery, right lobe hepatic necrosis commonly occurs. Okay, so when we are removing the cystic artery, we may also ligate or remove the right hepatic artery, and that may lead to hepatic necrosis commonly, the right lobe hepatic necrosis that may commonly occur. The splenic artery, which is moving in this direction, like over here. So the splenic artery runs a tortuous horizontal course to the left along the upper border of the pancreas behind the peritoneum or the posterior wall of the lesser sac, forming a part of the stomach bed. So stomach bed means all the structures which are located behind the stomach. So you can see that the splenic artery is present posterior to the stomach. So this is constituting the stomach bed. So the splenic artery may be subject to erosion by the penetrating ulcer at the posterior wall of the stomach into the lesser sac. There is an NBME point that the splenic vein runs more straight course below the artery and behind the pancreas. The splenic vein, so the splenic artery is more tortuous and it is moving on the upper border of the pancreas, while the splenic vein that is running a straight course in comparison to the artery, and that is running behind the pancreatic pancreas and stuff like that, below the artery and behind the pancreas. Then we have splenic artery. What was that? This was also splenic artery. Again they are explaining the splenic artery. So splenic artery is a retroperitoneal. The splenic artery is a retroperitoneal until it reaches the tail of the pancreas, where it enters the splenorenal ligament to enter the hilum of the spleen. The branches which are arising from the splenic artery are the branches which are going to the spleen, definitely, because it is splenic artery. Then branches to the neck, body and the tail of pancreas. The left gastroepiploic artery that supplies the left side of the greater curvature of the stomach, where it anastomoses with the right gastroepiploic artery. The left gastroepiploic artery coming downward like that. Then you have the short gastric artery, which are branches that supply the fundus of the stomach. Moving forward to the Uworld point over here, so you can see the splenic artery gives off short gastric artery, the pancreatic artery, the left gastroepiploic arteries and the splenic arteries. Due to the poor anastomosis, the gastric tube supplying the short gastric arteries is vulnerable to the ischemic injury following the splenic artery blockage. Then we have a Uworld point, that is splenic vein thrombosis, that leads to the isolated gastric varices. Okay, so whenever there is portal hypertension, we have varices. The concept of varices is that if there is engorgement of the blood in the veins, so that can result in a dilation of the veins, right? So if there is portal hypertension, the blood from the left gastric vein is not being drained, because that was supposed to be drained in the portal vein. So if it is not drained, so that accumulates in the left gastric vein, and that can result into esophageal varices. Now we are saying that is also true for the thrombosis. And now we are saying that in the splenic artery, if there is isolated splenic vein, if I said artery, it was vein. So same is true for the splenic vein. In the splenic vein thrombosis, there is isolated gastric varices because we know that the splenic artery, and now I'm talking about artery. Splenic artery supplies the spleen. It also gives the branches which are called the short gastric arteries, which are supplying the short gastric arteries are going to supply what? They are going to supply the part of the stomach. Now if we talk about the vein, the veins are also moving parallel to the arteries. So the veins are draining the spleen, as well as, if I draw a vein over here, so the vein will be draining the spleen, as well as the short gastric veins will give rise to will be the tributaries, and they will be draining the body and fundus of the stomach. So whenever there is thrombosis of splenic vein, there will be isolated gastric varices. You must remember this point. Moving forward, we have the short gastric vein drain the blood from the gastric fundus to the splenic vein. The pancreatic inflammation, for example, the pancreatitis and the pancreatic cancer, can cause a blood clot within the splenic vein. Yes, because there is an association with the pancreatic cancer that is called as superficial migratory thrombophlebitis, or Trocheus sign, that can cause migratory thrombosis in different veins, including the superior vena cava and the splenic vein, which can cause increased pressure in the short gastric vein and lead to the gastric varices only in the fundus. They ask you about this thing in the step 1 exams, so you must remember. So here you can see the splenic vein thrombosis. Suppose this is the point of obstruction. Okay, let me change the color. So suppose this is the point of obstruction, the splenic vein thrombosis over here. So due to that splenic vein thrombosis, what are we seeing? You can see that these are the right gastric vein, and not the right gastric vein, these are the fundal varices which are being formed. Like this splenic artery has been engorged, and the fundal varices have also been engorged, and the other venous tributaries are the same as those arteries. Like esophageal veins are coming from the left gastric vein or something like that. The left gastric vein, the right gastric vein is like present over here. This thing is the right gastric vein, like this. Then we have the splenic vein thrombosis, like as we have seen before. Splenic vein is this one. Then inferior mesenteric vein moving downwards, and we have the superior mesenteric vein like this. The Uworld point about the gastric ulcers, mostly from the lesser curvature at the transitional zone between the acid secreting epithelium of the corpus and the gastrin secreting epithelium at the antrum. Corpus means body. So the gastric ulcers, mostly from the lesser curvature at the transition zone between the acid secreting epithelium of the body and the gastrin secreting epithelium of the antrum, because the G cells are present in the antrum of the stomach. If I draw a stomach like that, suppose this is the stomach, like this. So this region is the fundus, this is the body of the corpus, and here we have the antrum, right? This small region is called as the cardia, the opening of the stomach, and then we have the pylorus. So they are saying that the most of the ulcers are present at the curvature, like this thing, at the transition zone between the cardia, between the body, which is basically responsible for the production of acid, and the antrum, that is responsible for the secretion of gastrin. So most of the ulcers are being formed at this particular point. Then we have the duodenal ulcers. They are seen most commonly in the anterior wall, and they may also result in perforation. In the posterior wall, if there is perforation, most of the duodenal ulcers are present. Suppose this is the duodenum, so most of them are present in the anterior wall. But if they are present on the posterior wall, so we know that in the posterior wall of the duodenum we have an artery that is called as the gastroduodenal artery, right? Or maybe the pancreatic or duodenal artery, you may say that. So if there is an ulcer, a duodenal ulcer is located in the posterior wall, so there is hemorrhage of the gastroduodenal artery, and that may result in frank hemorrhage. On the lesser curvature, the hemorrhage is coming from the left gastric artery mostly. Then we have head of the pancreas is supplied by the superior pancreatic or duodenal artery from the gastroduodenal artery, and the inferior pancreatic or duodenal artery from the superior mesenteric artery. So these are the two kinds of blood supply. Like the pancreas is getting blood supply from the artery of the foregut as well as the midgut, because the superior pancreatic or duodenal artery is coming from the celiac artery, while the inferior pancreatic or duodenal artery is coming from the superior mesenteric artery. So here you can see the anatomical area and the supplying artery. The proximal lesser curvature, like this part, like the proximal lesser curvature, this thing, it is supplied by the left gastric artery coming from the celiac artery. The distal lesser curvature is coming from the right gastric artery, also coming from the celiac artery, but it is the right gastric artery is coming from the proper hepatic artery, which originates from the common hepatic artery, which originates from the celiac artery. The proximal greater curvature is supplied by the left gastroepiploic artery, which is coming from the splenic artery, and splenic artery in turn is originating from the celiac artery. The distal greater curvature It is being supplied by the right gastroepiploic artery. The right gastroepiploic artery is coming from the gastroduodenal artery, which is originating from the common hepatic artery, and that is originating from the celiac artery. Then we have the proximal greater curvature above the splenic artery. Proximal greater curvature above the splenic artery. That is supplied by the short gastric arteries, and short gastric arteries are coming from the splenic arteries, and splenic artery is coming from the celiac artery. Simple. Then we have superior mesenteric artery and its branches. So superior mesenteric artery was coming at the level of L1, I guess. L1. Yes, it was originating at the level of L1, and then the inferior mesenteric artery was coming at the level of L3. So the superior mesenteric artery, as depicted over here, so it gives rise to inferior pancreatic or duodenal arteries, which is supplying the head of pancreas. Then jejunal and ileal branches, like these all are jejunal and ileal branches supplying the jejunum and ileum. Then we have the ileocolic artery, which has an ascending branch, the anterior cecal artery, the posterior cecal artery, then appendicular artery, which supply the appendix. Okay, so then we have the right colic artery and the middle colic artery. The right colic artery is supplying the ascending the right colic artery is supplying the ascending colon because it is on the right side. And then we have the mid colic artery, which is supplying the anterior proximal 2/3 of the transverse colon. Then here you can see the inferior mesenteric artery and its branches. It is going to give rise to the left colic artery, which is supplying the descending colon because it is on the left side. Then sigmoid arteries, which are supplying the sigmoid colon, and the superior rectal artery is also coming from the inferior mesenteric artery. There is a Uworld point that superior mesenteric artery and inferior mesenteric artery are two main vessels supplying the small and large intestine, and they are connected by a pair of anastomosis. The marginal artery of Dermond, which is a marginal artery, which is the principal anastomosis, and the inconsistently present arc of Riolan mesenteric meandering artery. So these are the arteries which are going to give us the anastomosis between the superior mesenteric and the inferior mesenteric artery. The main one is the marginal artery of Dermond, and the second one is the arc of Riolan. These anastomosis protect the intestine from the ischemia. So here you can see the marginal arteries. So if I could zoom it in, so you can see it better. So these are the marginal arteries, like these, I guess these are the straight arteries. The marginal artery is maybe this one, like there is a continuous connection. Okay, so there's marginal artery. So they are saying that these not straight arteries, these circular arteries, these are marginal arteries. Then we have arc of Riolan. I don't think they have depicted it, the arc of Riolan over here. So we are good to go. Then remember the names, the marginal artery and the arc of Riolan. These are the main anastomotic arteries between the superior and inferior mesenteric arteries. These anastomosis protect the intestine from ischemia. Due to the marginal artery, the inferior mesenteric artery is not always reconnected during the aortic aneurysm repair. So whenever we are doing the aortic aneurysm repair, so we have to cut, maybe sometimes we have to cut the blood supply of the inferior mesenteric artery, and in some situations we don't even reconnect the inferior mesenteric artery because we know that there is marginal artery, and the anastomotic channels, they will compensate for the blood supply to the colon, to the left side of the colon, like the descending colon, the sigmoid colon. But the patient is asked to take to eat less and stuff like that. The physical activity must be decreased, and there are some precautions that which the patient is supposed to take. Then we have the portosystemic anastomosis. The portosystemic anastomosis is basically the connection between the portal venous system and the systemic venous system. The portal system is a special system. Like suppose all the blood that is draining from the GIT, like from below the diaphragm, all the blood that is draining from the GIT is first going to the liver and then to the systemic circulation. This shunt pathway is called as the portal shunt or the portal system of veins. And the systemic system of vein is the one which contains inferior vena cava and superior vena cava. The blood from all of the body drains into the vena cavas and then to the right atrium. But from the GIT there is a special connection that firstly it goes to the liver by the portal system and then it enters the inferior vena cava. So here whenever there is some problem with this pathway, like the liver is not functioning properly, there is going to be an increased pressure in the portal system. There are certain positions or certain points in the body where there is a direct connection between the portal venous system and the systemic venous system. And whenever there is portal hypertension, in those particular situations, the portosystemic anastomosis becomes dilated, right? So we'll see the three main points. So in the very first point, they are saying the pathological blood flow in the portal hypertension flows to the tips. Okay, so normal venous drainage, how is that taking place? Let's see the normal venous drainage. The normal venous drainage is, let's suppose that from the GIT, the blood enters the portal venous system. From the portal venous system, the blood goes to the hepatic veins, and from the hepatic vein it goes to the inferior vena cava, and then all the way into the from the this thing that we call the to the inferior vena cava and stuff like that. Then the next thing is, if there is some sort of so this is portal system, and for the inferior vena cava, you must remember, like the suppose we are talking about the periumbilical veins, they are draining the blood from the umbilicus, they are moving downwards, then to the inferior vena cava, and then all the way to the right side of the heart. If there is pathology, like suppose there is some sort of liver cirrhosis, and due to the liver cirrhosis, the liver is compressing the hepatic portal vein, and the pressure inside the portal vein has increased. Now what happens? Now the blood from the portal vein, instead of going forward, start moving backwards. Now when it moves backward, it will come back all the way to here, and at the junction of the portosystemic area, the blood from the portal vein will start shunting into the systemic circulation, and these anastomotic areas becomes dilated. The same is true at the side of rectum, that this blood will move downwards, and this system, this channel, instead of taking the blood towards the liver, it starts shunting the blood backward so that it could be drained with the systemic circulation, the middle rectal vein and the inferior rectal vein. So superior rectal vein, it is a part of the inferior mesenteric vein, right? And inferior mesenteric vein, how is portal vein formed? The portal vein is formed by the confluence of the splenic vein, the inferior mesenteric vein, and the superior mesenteric vein behind the neck of the pancreas, and then it forms a portal vein. From the inferior mesenteric vein, the blood is drains from the rectum via superior rectal veins, and then it drains in the inferior mesenteric vein. If there is portal hypertension, instead of taking the blood from the rectum to the inferior mesenteric vein, the blood starts shunting back towards the rectum, and when there is shunting of the blood back towards the rectum, there is dilation of the portosystemic shunt. At this point, there is another thing that you must remember, that whenever there is cirrhosis, there is a therapeutic shunt that we place in the liver, that is called as the TIPS. So the TIPS stand for the transjugular, I'm sorry, I'm forgetting the name of that. It is transjugular intraperitoneal shunt, maybe, I don't know. It is transjugular intrahepatic portosystemic shunt. Yeah. So inside the liver, we connect the portal vein with the hepatic vein. This is basically a stent. So we introduce the stent from the jugular vein, we go all the way till the hepatic vein, and then from the hepatic vein we make a connection between the hepatic veins and the portal vein. So this is called the TIPS procedure. There are some problems or some complications which are associated with the TIPS procedure. For example, the hepatic encephalopathy, uremic hepatic encephalopathy is also associated with this one, but we'll see that in detail later on. For right now, let's talk about the varices. So the site of anastomosis is present at the esophagus, the umbilicus, and the rectum. So the mnemonic for that is varices of gut, butt, and caput are commonly seen with the portal hypertension, caput medusae. So the esophagus, the clinical sign for the esophageal varices are for the esophageal hypertension is the esophageal varices, and it happens when the left esophagus vein starts draining, left gastric vein, which is a portal artery, which drains into the portal. I'm sorry, I say artery again and again. The left gastric vein that is going to drain in the portal vein, instead of going to the portal vein, it starts draining into the azygous vein. The azygous vein is a systemic vein, the left gastric vein is the portal vein. So this portal vein, instead of going to the liver, it starts draining itself into the azygous vein, and that leads to the formation of esophageal varices. The umbilicus, at the level of umbilicus we get caput medusae. In this case, the para-umbilical veins, which are portal veins, they start draining into small epigastric veins of the anterior abdominal wall, and when they drain into the small epigastric veins of the anterior abdominal wall, that will lead to the formation of caput medusae. In the periumbilical region, at the level of rectum, we have anorectal varices, and the anorectal varices, the superior rectal artery, which is a portal artery, which drains into the inferior mesenteric artery, the superior rectal vein that is going to drain in the inferior mesenteric vein, and then to the portal vein. This is the portal vein, and the middle and inferior rectal veins, they are going to drain in the the iliac veins, I guess, the internal iliac veins. So that is the systemic vein. So there is a portosystemic shunt between the superior rectal veins and the middle and inferior rectal veins, and that will lead to the formation of anorectal varices. The treatment is treatment with the transjugular intrahepatic portosystemic shunt between the portal vein and hepatic vein relieves the portal hypertension, but by shunting the blood to the systemic circulation bypassing the liver. It can precipitate the hepatic encephalopathy because the blood is never entering the liver. The blood that was supposed to go into the liver, that is shunted directly into the hepatic veins and then directly into the inferior vena cava. So the urea cycle that was supposed to be running in the liver is shunted, is bypassed. So the person can develop uremic hepatic encephalopathy because of hyperuremia or hyperuricemia. We'll keep this session till here, and we'll continue with this one in the next session. Until then, Allah Hafiz, fi amanillah, and take care.